Hello, Dr. Gordon. How are you?
Hello, Alex. What's happening?
A lot. Welcome. This is our live interview. Um, getting ahead of aneurysms and stroke. What you need to know and stay healthy. Uh,
You look good.
oh, thank you. I appreciate that. You look good as well. This program is brought to you by Northwell Health, Neurosurgery, and the Center for Healthy Living. I'm going to be your moderator today. My name is Alex Eusebio, and I'm the Director of Operations for the Department of Neurosurgery. With us tonight, we have Northern Westchester Hospital's neurosurgeon, Dr. David Gordon. Hello, Dr. Gordon.
Hi, Alex.
Dr. Gordon is our chair of the Department of Neurosurgery at Northern Westchester Hospital, and he's the regional chair of neurosurgery in Westchester. Tonight, our neurosurgeon, Dr. Gordon, will be talking about aneurysms and stroke. Dr. Gordon will discuss common myths about brain aneurysms at any age and the latest advancements in care, including treatments available at Northern Westchester Hospital. We'll also share a brief video where you'll have a chance to meet the neurosurgeons providing care in Westchester at both Northern Westchester Hospital and Phelps Hospital. As time permits, at the end of the program, we'll take questions and answer any and some of your pre-submitted questions from registration. Please put all questions in the chat or QA function. If your question is not answered during the presentation, please feel free to go to our website, which is nwh.northwell.edu/contact us. At any time during this presentation, if you're interested in booking a consultation with us, please message us, private message us using the chat function with your name and contact information. One of our providers will contact you and assist you in answering your questions or booking a consultation. You can also ask to provide your contact info in the survey at the end of this program. Your contact information will be kept confidential, of course. Whatever you write there will be kept between yourselves and us. To schedule a consultation with Dr. Gordon, please call 914-269-1930. Thank you very much for allowing us to present to you guys, and we're going to get started. So I would like to introduce to you Dr. David Gordon. Hello, Dr. Gordon.
Hey, Alex.
So, Dr. Gordon, what is a brain aneurysm?
A brain aneurysm is like a little blister or a balloon that represents a weakened portion of a blood vessel wall that's along one of the blood vessels that's supplying blood to the brain.
Interesting. So how are these brain aneurysms treated?
A lot of brain aneurysms actually don't need to be treated. Based on certain characteristics of the aneurysm or of the patient with the aneurysm, we often wind up monitoring aneurysms over time. When aneurysms do need treatment, there are generally two ways to treat aneurysms. One is through open surgery, where we take a spring-loaded metal clip and place it across the neck of the aneurysm. If this is the balloon of the aneurysm, the clip goes across the neck to block blood flow into the aneurysm. More recently, there are a lot of endovascular options for treatment of aneurysms. When I say endovascular, I mean minimally invasive catheter-based techniques where we actually travel through the blood vessels themselves and block the blood flow into the aneurysm from the inside of the blood vessel.
And what are the newer techniques in treatment of those brain aneurysms, whether clip or minimally invasive?
Right. So, aneurysm clipping or surgical clip ligation, the open surgical techniques have been around for many decades. There have been advances in terms of operative instrumentation and devices within the operating room to make the open surgery safer. But the real exciting changes in the treatment of aneurysms have been on the endovascular, the catheter-based side of things, where there's been rapid development of both techniques and devices to provide minimally invasive, safe interventions to treat those aneurysms. And the more recent developments have been the use of devices that actually change the flow either in the blood vessel that the aneurysm is coming off of. This is called flow diversion. And there are devices now that are able to be placed within the aneurysm itself that block the blood flow from inside the aneurysm. We call these intrasaccular flow diverters. So there's really exciting developments that provide a much more streamlined and safe intervention for patients with aneurysms.
So we have these great new treatments and techniques, but how does someone know if they have an aneurysm? Are there any symptoms?
It's a great question, Alex.
Right.
So a lot of aneurysms we find what we call incidentally, meaning that there aren't symptoms associated with them, and with the increasing use of MRIs for symptoms such as headaches or other neurological issues, we're discovering aneurysms in patients. And so these are essentially asymptomatic. The main symptom of an aneurysm is if it ruptures, if it bursts. And when it bursts, it invariably causes the sudden onset of the worst headache of somebody's life. So we all have headaches, and there are 150 different reasons why headaches occur, but this headache is very different. It's sudden onset. People describe it as a thunderclap or a lightning bolt, and it's quite severe. So that's an indication that you should go to the hospital in a timely fashion in order to make sure that it's not an aneurysm that has caused that headache.
And now we can do that in Westchester.
And
Dr. Gordon, I have another question. What is a arteriovenous malformation?
So an arteriovenous malformation, also we shorten this and say AVM. An AVM is an abnormal connection of abnormal blood vessels. So the blood vessels are abnormal, and the connection between the blood vessels is also abnormal. And arteries, which bring blood to tissue, and in this case to the brain or to the spinal cord, the arteries are directly connected to veins, which are draining blood away from the brain or the spinal cord. And so this is an abnormal tangle of blood vessels that carries with it a risk of a bleeding event occurring. Occasionally in the brain, it carries a risk of seizures also.
And how are these brain AVMs, as you call them, treated? Is it the same as aneurysms? Is it different?
So conceptually, it's the same, but they're different animals. And so the strategy for treating AVMs is a little bit different. There are techniques also catheter-based, just like with aneurysms. We call it endovascular embolization. And this is a procedure where we guide catheters through the blood vessels of the body, and through smaller catheters, we're able to inject glue-type substances that block blood flow to the AVM. This can be done as a standalone procedure in certain cases, but the definitive treatment for most AVMs is surgical resection. The embolization procedure, the catheter-based blockage of blood supply, is often used in conjunction with surgical resection in order to make the resection safer for the patient. There's also a modality called stereotactic radiosurgery, which actually isn't surgery at all. It's a technique where very high energy, highly focused radiation is delivered to the AVM, and that radiation, which is then not applied to the brain itself, but just to the AVM, causes involution, or the AVM to go away over time. And there are certain select AVMs that are best treated in that manner. So usually a combination of techniques are used. In our Northwell system, all patients with aneurysms or AVMs are discussed. We have a comprehensive multidisciplinary cerebrovascular conference on a weekly basis, where all the specialist providers involved in the care of patients with cerebrovascular disease discuss what the recommendations are. And sometimes there's some fisticuffs, but usually it's not violent. And we come to a conclusion as to what the safest method, which sometimes, by the way, is observation. Sometimes it's surveillance imaging and not an intervention at all. But then that consensus recommendation is given to the patient in a follow-up appointment.
Okay. Sorry, this question is not scripted. And the laser beam, is that called gamma knife?
The laser beam?
Yes, like the radiation for the AVM. Is that called gamma knife?
Oh, so the stereotactic radiosurgery. So there are different modalities to deliver stereotactic radiosurgery. The stereotactic part of this means that it's a framed based or a frameless based application where the delivery is designed conformally on a workstation involving a neurosurgeon, involving a physicist, and a radiation oncologist. And so conceptually, the different methods are the same. And then that radiation is then delivered based on what the workstation throughput is. Gamma knife is one kind of stereotactic radiosurgery. It's a very effective modality, and there's a gamma knife unit at Northern Westchester Hospital, and so we use the gamma knife. There's also a linear accelerator. There are other ways of delivering stereotactic radiosurgery, but we use gamma knife.
That's what I was leading towards.
Yeah.
Little self promotion. And Dr. Gordon, what are the different types of stroke, and what is a stroke? Sorry, first question.
So stroke is really an umbrella term that relates to a vascular problem in the brain. So there are two general kinds of stroke. One is the ischemic kind, and the other is the hemorrhagic kind. The ischemic strokes are when there's a blockage of blood supply to the brain. So the brain is starved of blood, and that leads to neurological problems. And then the hemorrhagic kind of stroke is when there's a bleeding event. So for instance, a ruptured brain aneurysm is a kind of hemorrhagic stroke. A ruptured brain AVM is a kind of hemorrhagic stroke. There are also hemorrhagic strokes where there's rupture of small blood vessels in the brain that cause blood clots to form. So those are the two major different kinds of stroke.
Okay, so ischemic, you're closing, and hemorrhagic, you're opening.
That's right. Yes.
Thank you. Thank you for explaining. I learn something new every day. How do you know if you're having an ischemic stroke versus a hemorrhagic stroke?
So the symptoms tend to be different. Ischemic strokes, there's a mnemonic to try to recognize whether or not you are having an ischemic stroke, and that is BEFAST, BEFAST. And this refers to the sudden onset of changes in balance or dizziness. E stands for eyes. So if you have visual changes or blurred vision or doubled vision. F is face. So if you have numbness or weakness on one side of the face. A refers to arm and leg, but L didn't fit into the mnemonic. So if you have weakness or numbness on one side of the body and the arm or the leg, that should be a red flag that there's a neurologic event happening. And then S is speech. So if you have trouble speaking, you have trouble understanding speech, you have language difficulties, this is another sign that an ischemic stroke could be occurring. And T stands for time. So if any of these symptoms occur, it should alert you that you may be having an ischemic stroke and you need to get to a hospital quickly. You call 911 so that you can be rapidly evaluated in the emergency department and with the multidisciplinary stroke team awaiting you in the hospital.
Thank you.
And I don't think I got to, so that's ischemic stroke. Hemorrhagic strokes can present differently. We've talked already about aneurysms. So a ruptured aneurysm or a bleeding aneurysm causes the sudden onset of the worst headache of your life. Hemorrhagic strokes usually involve headaches, and they could be sudden onset headaches. They could be severe headaches. They tend to be headaches that come on and then progress. And these symptoms that I've described for ischemic strokes also can apply to hemorrhagic strokes, where those symptoms also progress. So the hemorrhagic stroke usually involves progression of neurologic symptoms in association with a headache. Ischemic strokes, you could have an associated headache, but headache is less of a red flag or less of a presenting symptom. It's more commonly associated with hemorrhagic strokes.
Thank you. So you mentioned the newer techniques in hemorrhagic treatment, but can you go over that again, and plus the newer treatments for the ischemic treatments of stroke?
Sure. So, again, as certainly in the course of my career, we've seen more and more aneurysms treated with these catheter-based endovascular techniques. And we talked a little bit about device development, and these are not experimental devices; these are FDA-approved devices that are used for the endovascular treatment of aneurysms. AVMs, we talked about how to treat AVMs if they rupture. Hemorrhagic strokes, they often don't need surgical intervention, but they do need a multidisciplinary team caring for the patient, usually in the intensive care unit or a stroke unit. And this involves medical support in order to prevent progression of the stroke. When hemorrhagic strokes or blood clots inside the brain need to be addressed, this can be addressed through open surgery, but there are also newer, more minimally invasive techniques involving endoscopes or small little cameras that can be inserted into the blood clot, evacuating the blood clot without disturbing the brain. So these are some new developments in the surgical management of hemorrhagic stroke.
Thank you. Interesting. So it sounds like it's important when you have these symptoms to get to the hospital as quick as possible, so these providers can identify which category you fall into and get you the proper treatment in time.
That's absolutely correct. So, any of these, it doesn't make sense to wait to see if things are getting worse or if things are getting better. If you have any of these, the onset of any of these cardinal symptoms, then it behooves you to come to the hospital via 911 as quickly as possible, so that at least a stroke can be ruled out. And if a stroke is identified, then rapid intervention can be pursued if it's indicated. The treatment of ischemic stroke is there's been a sea change in how we treat ischemic stroke or certain kinds of ischemic stroke. It's a very exciting time in kind of the stroke world, because we have procedures done also via catheters. So through a small needle that's placed either in the top of the leg, in the femoral artery, or into the wrist, which is the radial artery, we can feed catheters, and then using x-rays guide the catheters to where certain blood clots are that are blocking blood flow to the brain. The procedure is called an endovascular mechanical thrombectomy. And all that means is that we are going in and removing blood clots, restoring blood flow to the brain. And there's dramatic change in the outcome for a certain subset of patients, patients who may have died from large ischemic strokes or been debilitated for the rest of their lives, are actually now walking out of the hospital because of this procedure. So it's a very exciting time in the stroke intervention world, which
I have to say that is one of the most gratifying things in my job, is that one time a year when we kind of throw these conferences and see patient testimonials. I mean, you talk about it, but just seeing it and seeing the results and letting the results speak for themselves is just so gratifying. That's the word that comes to mind. But thank you for sharing.
No. Listen, I agree. And the other part of this, in terms of the endovascular intervention for ischemic stroke, is that because of the development of the device development, the technical developments going on, we are actually able to retrieve smaller blood clots that are farther along in the tree of the blood vessels that go to the brain. And so there are more and more people that are able to be helped by intervention in a disease process that prior to this was only supportive. So it's really very gratifying. to see patients being able to be restored to their normal lives.
This is a good time to segue on that point to view a brief video where you have a chance to meet the neurosurgeons providing the types of care that Dr. Gordon was speaking about at Northern Westchester Hospital and Phelps Hospital. So Amy, you can start the video now.
I'm David Gordon. I am the chief of neurosurgery at both Northern Westchester Hospital and Phelps Hospital. There's a lot of excitement for building this collaborative effort between the two campuses, what we call Northwell Health Neurosurgery Westchester.
Our goal is to bring highly subspecialized care into the Westchester community.
We have all the services. They don't have to go down to the city and travel and be further away from their own community.
We want to build something really special in Westchester County. These hospitals are both known for their patient experience. We realized over time, especially with our Lenox Hill success, that when you put good groups of people together, provide mentorship, support, you can do really outstanding work at a higher level in these great hospitals.
Being part of Northwell Health gives us tremendous resources necessary to take care of these complex neurological and neurosurgical patients. And it's what got me incredibly excited to come up here.
There's a lot of innovation going on in neuroscience and neurosurgery in particular, like navigational guidance and some of the imaging modalities. What we bring, though, is a combination of having the state-of-the-art technology along with the state-of-the-art culture.
We tend to say that time is brain for a stroke. So when a patient is having a stroke, that patient needs to arrive to a hospital as quickly as possible.
There's been this sea change in stroke care. We are able to do procedures which are minimally invasive, and patients who would have been profoundly debilitated or even have died are now sometimes able to walk out of the hospital without any deficit. This is the most exciting thing that's happened in my time in medicine, and this is care that is currently being delivered at Northwell Health Neurosurgery Westchester.
We develop our pituitary tumor center. We do offer the newest technique in pituitary surgery, which is the endoscopic endonasal surgery. We have an incredible group of specialized doctors in the areas of endocrinology, ENT.
There's a very robust oncology program. The ability to offer comprehensive multidisciplinary oncologic care for neurosurgical patients is something that I'm very excited to help grow. There's a gamma knife unit that's in the hospital. This is the only one in Westchester County.
Between Syracuse and New York City, the only gamma knife facility is at Northern Westchester Hospital.
It's a minimally invasive, highly effective, very safe approach for the management of these complex disease processes.
We can bring the same quality that I certainly experienced when I was working in a major academic center. I think the advantage is that we do it in a more intimate surrounding.
One of the most rewarding things in neurosurgery is that you're really able to make a big impact in patients' life. I treat all my patients like they're my own family members.
What we have assembled here, it's no different to any top center in the whole country.
Usually you choose your doctor. Here you choose a team. Our success is based on seeing other people successful, most importantly the patient. That's unique in the New York market. It's nothing like it.
There's something really special about Northwell Health Neurosurgery Westchester. No matter what treatment you need, we've got you covered. I gain a profound sense of satisfaction for being able to help guide the patients and their families through the process.
I'm most proud of my patients and the patients that I save. I think nothing beats that.
Alex, I can't hear you.
Can you hear me now?
Yeah, I can hear you now.
Awesome. That was a test. We're going to have an interactive poll game regarding some common myths to play along. You'll need to see a Zoom poll questions pop up on your screen. Take a guess and answer the question, or just watch and play along with us. Dr. Gordon will explain the answers as we go. Now, let's get started. True or false? If your brain bursts, can you survive?
Am I waiting for the poll? I just voted.
So I guess we'll give a minute or two. Yep.
Ha.
The answer is everybody thinks true.
Everybody's right. So, listen, you know, an aneurysm bursting or rupturing is a very serious event, as one can imagine. There's no question that the majority of patients who have aneurysms that rupture survive. The key is that if you experience, again, the sudden onset of the worst headache of your life, that you call 911 and you go to the hospital, because timely intervention is important. Timely evaluation by the multidisciplinary team that's going to be awaiting you at the hospital. You're going to have very experienced emergency department providers. The nurses are phenomenal. Critical care medicine, stroke neurology, neuroradiology. You know, there's a whole team that's geared towards the acute care of patients who have ruptured aneurysms. So the important part of the answer to this question is that, yes, you can survive, but you want to be evaluated as quickly as possible.
Thank you. Okay, we're ready for our next question. Myth. Stroke warning signs are difficult to recognize. True or false?
Did you vote?
I did.
I hope you've got the right answer. Okay.
Ooh, this one split down the middle. I know what I voted.
All right. So the truth is that unless you know them, that of course they're difficult to recognize. But part of what we're trying to do now tonight is to educate you about the fact, for those of you who don't know, that they're not difficult to recognize. And the acronym, the mnemonic we use is B FAST. It's B as in boy, E, F as in Frank, A, S as in Sam, and T. And to go through them again: balance, eyes or change in vision, face, so weakness or numbness on one side of the face, arm, which includes leg, so in your extremities, if you have weakness or numbness in your arm or your leg on one side. And then S is speech, so difficulty speaking, finding the right words, or understanding speech. These are the cardinal symptoms of stroke onset. So if these occur, and they don't all have to occur, if any of them occur and they occur acutely, then T, time, call 911 and go to the hospital and be evaluated.
Excellent.
So they're not difficult to recognize, but they are unless you keep reminding yourself of what they are.
So true and false was correct on that.
So everybody's right. Again.
Okay. Myth number 3. Neurologists and neurosurgeons are the same thing.
All right. So everybody said false, and everybody's correct again. Neurologists are actually real doctors, and neurosurgeons are mechanics. So the neurology and neurosurgery have to work closely, because conceptually we're dealing with diseases of both the central and the peripheral nervous system. Neurologists deal with the non-surgical management of these diseases, some of which are never surgical diseases and are complex disease processes that involve medical intervention. And then neurosurgeons deal with the surgical or procedural interventions for disease processes that are amenable to procedures or surgery. there's significant overlap. And so neurologists and neurosurgeons need to work very closely for many neurologic or neurosurgical patients. This includes epileptologists. This includes vascular or stroke neurologists. There are subspecialties within neurology where we cross paths on many patients, cognitive neurology. So while we're different and we're different in our training, conceptually, we're not in silos, and really we're talking about the need to address a specific patient and a specific patient's disease process. And neurologists and neurosurgeons, along with many other disciplines, take care of those patients and those problems. In the hospital, we're talking about emergency medicine, we're talking about nursing, we're talking about critical care nursing, critical care medicine, hospitalists, anesthesiologists, radiologists, and I mean, everybody is geared around the care of the neurologic illness at hand. But you see a neurologist and a neurosurgeon initially for different things.
Thank you. That's very interesting. So the next poll question is, you can't tell the difference between brain aneurysm symptoms and stroke symptoms, true or false?
So this is a little, well, I'll wait. I got to submit my answer anyway.
Oh, split
Right.
down.
So it's split. So, and it should be split because it's a little bit of a confusing question. So again, strokes, when we're talking about stroke, we're talking about both ischemic and hemorrhagic stroke, and aneurysms, as we've discussed, is a kind of, when aneurysms rupture, that's a hemorrhagic stroke. In general, when we use the word stroke, we're referring to ischemic strokes. Just when we talk about stroke, they are much more common than hemorrhagic strokes, and it is more of the communal understanding of stroke is an ischemic stroke, which is the blockage of blood supply to the brain. So in that sense, it is relatively easy to tell the difference between aneurysms and ischemic strokes, because again, aneurysms present with the sudden onset of the worst headache of someone's life. Ischemic strokes or blockage of blood supply, they present with the symptoms of the be fast mnemonic. So balance, eyes, face, arm, leg, speech, and then time.
Great. Thank you. So the next myth is brain aneurysms and stroke are the same. Yes and no. Brain aneurysms and strokes are the same thing, true or false? A lot of trick questions.
Right.
Gordon?
So I mean, we've talked about this in a few different ways, but in general, brain aneurysms that rupture, a ruptured brain aneurysm, is a kind of stroke. A brain aneurysm on its own is not a stroke. A brain aneurysm is a structural problem with one of the blood vessels. A stroke is an acute event. So, and again, can be ischemic or blocking blood supply, blockage, or hemorrhagic, where something ruptures or bursts and causes bleeding. So a ruptured aneurysm can be a kind of stroke, but an aneurysm by itself is not a stroke.
Thank you. That's very good. I think a lot of interesting questions, and the chat is busy here, people asking questions. So we went into various topics of stroke, ischemic, hemorrhagic. At Northern Westchester Hospital, what safe precautions do we take regarding COVID-19? Amy, you want to show the PowerPoint, and maybe Dr. Gordon could go into a little bit of the, what we're doing at Northern Westchester Hospital to ensure the safety of the patients that we treat.
Sure. So first of all, I want to say that it is very safe to come to the hospital and have your surgery or your evaluation or your hospitalization relative to COVID. Um, you know, One of the reasons is the volume of COVID currently is low, but really has to be attributed to the entire hospital staff, from the providers on the ground during COVID, all the way up through administrative leadership in terms of creating protocols that have been flexible based on both what guidelines from a state perspective are and federal guidelines, but also internally. They've been much more rigorous in order to be able to keep everybody, all patients safe. And these are designed to prevent transmission of COVID within the hospital, from patient to patient, and also for providers. So, guidelines for what you need to prepare in order to come to the hospital for, say, your operation, for instance, have been changed. But currently, if a patient is fully vaccinated 2 weeks prior to surgery and has not been in contact with a known COVID-19 positive patient and has no COVID-19 symptoms in the last 10 days, you no longer need to get the COVID swab before your surgery or your procedure. If you have not been vaccinated, then you need a COVID swab within 3 days prior to surgery, in order to make sure that you are COVID negative and you're not an asymptomatic carrier. Occasionally there are COVID positive patients that require interventions on an urgent or emergent basis. And when this happens, these procedures are done at the end of the day. They're completely isolated through their entire stay in the hospital. There are procedures performed on COVID positive patients who are greater than 10 days asymptomatic, and 21 plus days asymptomatic in an immunocompromised patient. So all patients and staff, when we walk in every morning, we're screened in terms of symptoms, and we have our temperature taken. All patients are required to wear masks in the hospital, and staff wear PPE. We are stocked with PPE. There has not been a shortage, and based on whatever is applicable to the situation, we will wear N95s, we'll wear goggles, gowns, face masks, whatever is necessary. There's also the Purple Sun, which is an ultraviolet light application that assists with terminally cleaning operating rooms in order to keep patients that arrive in the operating room next safe from COVID. Currently, we're allowing one support person in the ambulatory surgery center waiting area, but there's a reminder here that there's no eating or drinking, and all COVID protocols must be followed. And then only approved visitors are allowed back into the ASC, the ambulatory surgery center patient area, to accompany a pediatric patient or someone who needs a family member or guardian assistance. Everybody that has come into the hospital, patients, family members, all staff members, have been exceptionally responsive to our changing protocols. And because of that, because of the engagement from the community and from the employee side, this is a very safe place to come for your procedure.
Thank you, Dr. Gordon. Thank you for educating us on all the safety precautions and all the measures taken at Northern Westchester to ensure that, everybody's having a safe treatment, and we're very aware of COVID and how to make sure that everybody's treated safely. We have some questions that were asked of the group here, the attendees. The first one is, are all strokes one-sided? Or can they be one-sided?
That's a great question. When we're talking about ischemic strokes, the large majority of symptoms are one-sided. And that's because the majority of ischemic strokes, which are, again, strokes where there's blockage of blood flow to the brain, occur in the front part of the brain. And the right side of the brain controls the left side of the body, and the left side of the brain controls the right side of the body. So it's a hallmark of stroke onset to have one-sided symptoms. Having said that, in certain circumstances, symptoms can be on both sides bilaterally, but the vast majority of patients who are having ischemic strokes have one-sided symptoms at their onset.
Thank you. Thank you for clarifying. There was another question in regards to, is it true that approximately 1 in 4 individuals over the age of 65 have silent strokes?
We're starting to get more into a vascular neurology territory. We would need to define what a silent stroke is. So it is true that approximately 1 in 4 people over 65 have abnormal signal somewhere on their MRI of the brain. Whether or not these represent true strokes or a blockage of blood supply, I think is a matter of debate. So the clinical relevance of a silent stroke is unclear, but if there's evidence on imaging studies of having something that appears to have been a blockage of blood supply, even if there were no symptoms associated with it, then it makes sense to engage with your primary care physician and determine whether or not it's appropriate to see a neurologist.
Thank you. The next question is there anything you could prevent blood clots? What can you do to prevent blood clots?
Is that so? The before flying, is that the question? Or
no.
Okay.
Aerogenetic. Oh yeah, before flying. Sorry, I missed that part.
Right. So the blood clots, that we worry about for flying are generally blood clots that involve the deep veins of the lower extremities of the legs, which are different than the blood clots that we've been talking about in terms of going to the brain. So things to do to help prevent blood clots from occurring while you're flying. You need to stay hydrated. You should, Alex, in particular, avoid alcohol while you're flying because alcohol dehydrates you. And then you could do calf exercises while you're seated. And what's even better is to intermittently get up from your seat and walk. And the reason for this is that it increases blood circulation through the venous system of your lower extremities. So that's what I would recommend. But that's a little bit different than the blood clots that we're talking about relative to either ischemic or hemorrhagic strokes.
Are there genetic risk factors for blood clots related to stroke?
So yes, there can be, is the answer to that question. There can be something called a hypercoagulable state, which means that there could be genetic factors that lead to a propensity to clot your blood. These are relatively rare disorders. If there's an indication in your family that people have had blood clotting problems, actually blood clotting problems, whether there's too much clotting or too little clotting, then I would recommend that you bring that family history to the attention of your primary care provider in order to determine whether or not you need an additional workup to see if you're at risk.
Okay. I have a very specific question. I have a panelist that is asking, I have a 52-year-old brother who had a massive stroke. We don't know why, but his body has numerous clots. Am I at higher risk of getting a stroke seeing my brother had one?
So first of all, I'm sorry about your brother. So this kind of dovetails with my last answer. So you aren't necessarily at higher risk because your brother had a stroke at a relatively young age. Having said that, it would make sense to me to go to your primary care physician in order to be evaluated. One of the things that hopefully has been addressed, and if not, may need to be addressed with your brother, is whether or not he has this hypercoagulable state, or he has this proclivity or propensity to form blood clots. And so a primary care doctor or a hematologist may have evaluated him. And if there's any question about that, then that's information I would bring to your own primary care doctor in order to determine if you need additional investigation for these things.
Thank you. I have a couple more panel questions here. Are weight and high cholesterol risk factors for stroke?
So yes, high cholesterol, obesity are risk factors for stroke. The single most important risk factor for stroke is hypertension or high blood pressure. And so managed high blood pressure reduces your risk of stroke. So this is, again, emphasizes the need to see your primary care physician, to get well visit checks. One of the reasons for this is to ensure that you're not developing high blood pressure if you don't have it, and if you do have it, that it remains well controlled.
Dr. Gordon, can you comment on certain medication such as tenactplase, alteplase, Entrust, Eliquis for stroke management?
So I'm not the best person to do that, frankly, because my role in the care of stroke patients is not longitudinal secondary stroke prevention, which is what we're talking about here. So when we're talking about the clot busting drugs like alteplase, these are medications that can be given in order to break up blood clots in the acute setting. In terms of Entrust related to stroke prevention, I'm not the best person to comment. Eliquis is this is an oral anticoagulant that is effective in secondary stroke prevention, but is not indicated for everybody who has had ischemic strokes. And so my recommendation relative to these medications is that you need coordination between your primary care physician and a vascular neurologist in order to determine what the best medication regimen is in order to prevent additional strokes from happening.
And if somebody's fearing that they're having a stroke or aneurysm, or they're having some kind of symptoms, should they take an aspirin first before calling 911, or just call 911?
So that's also a great question. The answer is no, you shouldn't take an aspirin. An aspirin this is different than a coronary event. The coronary events are related to narrowing and blockage of blood supply in the heart. You may need an aspirin, but there's no evidence that I'm aware of at this time that you should self-administer an aspirin if you're having these symptoms. One of the reasons for this is that it needs to be determined whether or not you're having an ischemic stroke due to a blockage of blood supply, or a hemorrhagic stroke, which is a bleeding event. And an aspirin serves as a blood thinner, and an aspirin is not indicated, or is actually contraindicated in the setting of a hemorrhagic stroke.
Great, thank you for clarifying that. There's a few more questions. We have a couple minutes. What is the main risk for stroke? My mother died from a sudden hemorrhagic stroke at 67, struggling from overweight and high blood pressure for years. My brother had a disabling stroke at 53, not being on cholesterol meds. Both events were over 30 years ago.
Those are devastating events. And, again, I'm sorry that you had to go through this once, let alone more than once. So the main risk factor for stroke is uncontrolled high blood pressure. So I want to emphasize again, and I know I said this, but it's very important, especially with a family history, that you see your primary care doctor and you ensure that that you don't have hypertension, or that your hypertension is controlled. There are other risk factors involved: hypercholesterolemia. You want to eat healthily. Exercise is an important part of secondary stroke prevention. But the answer to the question, the number one risk factor is hypertension, high blood pressure.
Can you describe, I know you described it before, but what a mini stroke is?
So mini stroke is the transient symptoms that people have that are the symptoms of a stroke, but then they go away. So we use the term transient ischemic attack, and mini stroke and transient ischemic attack they're synonymous. So what that is an interruption of blood supply that causes neurologic symptoms, and those symptoms then resolve within 24 hours. But they could potentially herald a larger stroke from occurring. So when those symptoms occur, it's important to get timely evaluation for those symptoms as well.
Thank you. And a lot of questions, very interesting questions, actually. And do AVM hemorrhages present in younger adults?
So yeah, that's a great question. The answer is yes. Compared to especially ischemic strokes, which tend to occur in an older age group, AVMs they have epidemiologic peaks in children, as well as in skewing towards the younger adult population. And so the answer to the question is yes.
Okay, thank you. What treatment is there for severe headaches from a brain hemorrhage?
That's a great question, and it's a question that's very difficult to answer. Frankly, when there are prolonged headaches, there's a headache syndrome relative to a prior brain hemorrhage. We always involve our neurology colleagues. There are a lot of weapons in the arsenal. It can be an incredibly frustrating problem. Thankfully, most patients who have had headaches associated with their event, those headaches resolve, but when they don't, they can be incredibly disabling. There are medications, there are injections, there are procedures, but there's no question that the neurology team is the best specialized group to deal with prolonged headache syndromes.
Okay, thank you. The next question, was CT angiography used in stroke as long as the 1990s?
I don't want to answer this question wrong, Lee. I want to say no, not that CT angiography didn't exist, but CT angiography is used specifically now in a rapid diagnostic fashion because of the advent of mechanical thrombectomy, which is the procedure that we discussed earlier in the presentation, where we use catheters to remove blood clots from large vessels that have been blocked. So I don't know of CT angiography I don't know when the advent of adequate CT angiography was. I know that CT angiography at some level existed in the 90s, but in terms of what we use it for now, which is primarily the rapid evaluation as to whether or not a patient is a candidate for an emergent procedure to reverse a stroke from occurring. So that certainly didn't happen in the 90s.
Thank you. I just want to say these were great questions. I learned a lot today. I think that, the questions were fantastic. I've been this 20 years and I'm not sure if I started in 2000, so I'm not sure if the 90s they were using CT angiography for stroke. So that's a great question.
I was a resident in the 90s, so I don't remember anything. I was just surviving.
It was a haze. So one more question. If I experience a quick popping sound in my head, should I be concerned? What should I do?
So a popping sound in the head is not concerning for the issues that we've been discussing tonight. So a quick popping sound in the head is not a symptom of an ischemic stroke. It's not a symptom of an aneurysm rupturing. It's not a symptom of an AVM bursting. Having said that, if you have a recurrent quick popping sound in the head, makes sense to talk initially with your primary care doctor to see if there are any associated symptoms that can guide whether or not an additional workup should be made. If it's specifically on one side and close to the ear, then it could represent an issue with blood flow in blood vessels that are not in the brain, but outside of the brain. It could be something intrinsic to the ear itself. And then you would want to potentially see an otolaryngologist or an ENT doctor. But whether the popping sound is related to and should indicate that you should come quickly to the emergency room relative to these acute neurologic or neurosurgical emergencies, the answer is no.
Well, thank you, Dr. Gordon. I really appreciate your time, Amy, and the participants for asking such great questions. Again, if you feel like you have other questions that you want asked, please feel free to contact us at nwh.northwell.edu/contact us. We're more than happy to answer any and all questions. Please feel free to contact us. If you want a consultation with Dr. Gordon or any other of our neurosurgical providers, please call 914-269-1930. And we really appreciate you guys spending time with us. And please contact us if you have any questions. There's going to be a survey that will pop up on your screen. Your feedback is very important to us. The goal is to educate and let the community know the great things that are happening in Westchester and Westchester Neurosurgery at Northwell. So please give us your feedback. We want any and all comments. Thank you very much. On the survey, if you would like to be contacted to answer any personal questions or schedule an appointment, please make sure that you share your name and your phone number, and we will contact you. And everything is confidential.
I also wanted to just say that we're very excited to be here, to be developing this program for the community up here. So really, we look forward to you contacting us if there are any issues or any questions. I want to thank Alex also for trimming his beard.
A little bit.
So, thank you.
I try to look presentable for the group, but again, thank you. The survey is very important to us. I just want to say that one more time, because that's how we know if we're communicating effectively, if we're, providing the support you guys need and answering your questions. And please, if you can, take a little bit of time to answer those surveys. We appreciate it.
Thank you, everybody.
Thank you, everybody. Have a great night.